Хоп. Так, хоп. Ну, позовете, что. Вот.
Все на экране.
Угу. Все включено. Пожалуйста. Спасибо.
Good afternoon, our student. My name is Svetlana Vasilievna. I am the head of the Department of Propedeutics of Pediatrics. Today we are joined to talk about anatomical and physiological peculiarities of the children's respiratory system. Lecture for second year students. We will discuss the following topics: anatomical and physiological peculiarities of the children's respiratory system, and physical examination of respiratory system. From anatomy, you know that the respiratory system's tract consists of the upper respiratory tract and the lower respiratory tract. The upper respiratory tract includes nose, nasal cavity, sinuses, ethmoid, frontal, maxillary, sphenoid, larynx, trachea. The lower respiratory tract, which includes lungs, airways, bronchi, and bronchiolitis, is sex alveoli. Let's talk about the structure of the lungs. The right lungs has 10 segments. The left lungs has 9. You can see these segments on the picture. I will not review them in details, as it is anatomy subject. Next, we will discuss the development of a respiratory system. The germ of the lung appears in week's third of development. The laying of the lung is the bulging of the ventral wall of the palsy intestine, which spread in the caudal direction. Diverticula gives rise to epithelial lining and associated glands and trachea, larynx, and bronchi, as well as respiratory epithelium of alveoli. Connective tissue, cartilages, and muscles rise from mesenchyma, cells that are located around a growing bookmark. If the separate of the digestive and respiratory tube is not complete, abnormal messages may be detected between the larynx or trachea and the esophagus. The formation ends by the age of 12. Pathology and symptoms of intestinal damage and respiratory system in the form of allergic and Dysbiotic reactions are also explained. As a result, we can make an conclusion. Congenital lung malformations can completely restore by the age of 12. If early violation of embryogenesis occurs, there could be the following respiratory abnormalities: cleft of the heart palate, including wolf lock, stenosis and atresia of the larynx and trachea are the result of the disorder of organ, the recanalization after physiological obstruction. Fistula between esophagus and trachea. Lung agenesia is the absence of bronchus and pulmonary tissue incompatible with life. Aplasia of the lung. The main bronchus ends binding or rudiments of the low bronchi. The lung tissue is absent of their residence, no structure section of it. Hyperplasia of the lung is under development, small organ. Abnormal acuity is the reduction of or increase in number of lung beats. On this slide, you can see the upper respiratory system. Absence of accessory nasal sinus, narrowness of nasal passage, larynx, trachea, bronchi. Next, we will talk about anatomical and physiological peculiarities of children's respiratory system. Nose at nasopharynx. The nasal passages are narrow. The long nasal passage forms by 4 years. The nasal concha are thick. Mucus is tender, richly vascularized, which causes tendency to swelling and, as a result, leads to broncho-obstructive syndrome. In the submucosal layer, cavernosus tissue is underdeveloped, which explains rare nosebleeds. Inhaled air is slightly warmed up, so young children can't be taken outside at a temperature below 10 Celsius. The pharynx is relatively narrow and short. The lymphoid pharyngeal ring and crypts are poorly developed up to a year. That's why we don't see sore throats. Tonsillitis is rare. Paranasal sinuses. Not well found. Frontal sinus is absent. Maxillary, ethmoid, and sphenoid sinuses are particularly formed, but have very small size. Therefore, in young children, sinusitis is rare. All sinuses develop by the age of 15. Eustachian tube. Short, wide, strange. In young children more than Eustachitis. Nasolacrimal canal. Short and wide. Valves are poorly developed. Promotes the transition of inflammation from the nose to the conjunctiva of the eye, frequent conjunctivitis. Larynx. Narrow, short, funnel-shaped. It is located higher than fourth cervical vertebra in children compared with adults, at the sixth cervical vertebra. The cartilage is tender, supple. True vocal cords are short, high voice. At 12 years old, boys have longer vocal cords than girls. The angle of intersection of the ptoid cartilage in children under 3 years of age is rounded. Then it becomes sharper in boys. Children have narrow glottis until 7 years old. The mucosa is richly vascularized. A lot of lymphoid tissue can lead to edema constrictive laryngitis. Trachea. In children, the first 4 and 5 months, all children's trachea is funnel-shaped. Narrow the lumen, pliable wall. the cartilage is soft. The cartilaginous half rings are connected by a fibrous membrane. In adults, which is an elastic closure plate. Elastic tissue is poor developed. Greater mobility of the trachea. This can lead to slit-like collapse of the trachea and nausea, showing breathing stridor. The mucous membrane is rich in blood vessels, tender and relatively dry due to insufficient development of the mucous glands. Chest. Convex sagittal transversus. Dimension equal. For example, barrel-shaped. The ribs are connected to the spine at an angle of 90 degrees and are located horizontally. The chest is in a state of inspiration which gains the background or weakness of the respiratory muscles. Leads to a small exertion of the chest and shallow breathing. Children have relatively more on it than adults, more supple and elastic. And next, we will talk about anatomical and physiological peculiarities of the children's respiratory system. A newborn child has horizontal position of the ribs, insufficient development of elastic tissue, well-developed vascular system of soft mucoses and the interstice layer. Small exertion of the chest. Pleural breathing in children under 3 years old. Bronchial from to birth valve. Bifurcation of the trachea in newborns is at level 3, at 2 to 6 years old. It is at level 4 to 5, at 12 years old. It is at 5 of thoracic vertebra. The lumen on the bronchi is narrow, the cartilage is soft, elastic fibers are underdeveloped. Mucus is tender, richly supplied with blood. In children under 5 to 6 months old, It is a little smooth muscle. Muscle and elastic tissue are underdeveloped at an early age. Inflammation and narrowing of the lumen occurs faster. The main cause of obstruction, mucosal edema and mucus hypersecretion. Less important reason is bronchospasm. Lung. The number of alveoli is less than in adults. Alveoli are single chamber, less airy. In children of the first 2 years of life, it is richly vascularized. Connected fabric is well developed, weakly elastic. Therefore, they are less air and more full-blooded than in adults. The same factors predispose to the development of obstruction, emphysema, and atelectasis. The tendency to atelectasis is also due to an insufficient amount of surfactant. Up to here, the upper lobe in the left lung is less developed. The upper and middle lobes of the right lung are the same. Interlobar fissures are not expressed. There are no interlobar pleasures. Segmental structure is in adults. The functional features of respiratory system are the following: insufficient regulatory effect of the respiratory center and cerebral cortex, low drainage and protective function of the bronchial tree, including low secretory immunoglobulin A content. The tendency of the mucous membranes and submucous live edema and hypersecretion. Frequent occurrence of atelectasis. The repeat development of respiratory distress and respiratory failure. On this slide, you can see how the respiratory rate in children is measured. The respiratory rate of a newborn is 40 to 60 per minute. At 12 months old, the child's rate is 30 per minute. At 5-year-old child's rate is 20 to 25 per minute, and in adult child is 16 to 12 per minute. Now, let's talk about breathing characteristics. Depth breath. A newborn has a superficial breathing. Breathing tip. Newborns and infants have diaphragmatic abdominal tip of breathing and a mixed tip when they turn 2 years old. 8 to 10 years old boys develop mainly the abdominal tip, and girls have chest and abdominal tip. Breathing rhythm. Newborns have arrhythmic breathing. Pauses between inhalation and exhalation are uneven. The breath alternates with superficial. Breathing can be irregular until to the age of 2. Now we will review the features of the vegetative nervous system in children of early age. First year of life function prevails the parasympathicus division, which leads the bronchoconstriction, vasodilatation, increased sweating, increased persistence, and improvement of the tone of various parts of the gastrointestinal tract. Clinical manifestations of vegetative effects: pasty, swelling, thick mucus, hypersecretion, gastroesophagus reflex, regurgitation and vomiting, dyskinesia intestine, unstable stool, constipation. Now, let's discuss clinical examination of the respiratory system. Collection of symptoms, general examination, palpation, percussion, auscultation. Complaints. We have to assess the nature of caused by main symptoms. Cough. Dry or moist with sputum. Time of appearance: morning, evening, night. Its character: loud, soft, voiceless, barking, permanent, periodic causes.
Аудитория.
Третье. Dyspnea, permanent, during physical exertion, during rest or speaking. Character of dyspnea: inspiratory, expiratory, mixed, asphyxia, asthma. Other symptoms. Sputum in mild character, color, smell, consistency, fluid or gelatinous, pain in the chest, character, dull, acute, boring, person, location and irradiation. Hemoptysis. Now let's talk about the physical examination of respiratory system. We will examine the tip of child's respiration, nasal, oral, acting of nose wings in breathing. On this slide, you can see the face of a child who has adenoids. We can breathe through his mouth. Now, let's talk about the examination of the chest shape. These are physiological tips. Normal, normosthenic, asthenic, hyposthenic. Normosthenic has an angle of 90 degrees. On this slide, you can see the pathological shapes of the chest. Pathological emphysematous, paralytic, final shapes, rachitic, foetid. Faucet position in bed. Faucet autopnea with bronchial asthma. The child is sitting, leaning on the edge of the bed with raised shoulders. Behavior. Arousal and motor restlessness with DN 1-2 degrees. Stenotic laryngotracheitis, asthma attack. On this slide, you can see position of autopnea. We will examine the skin color that children with lung pathology can have. Peral cyanosis is typical of cyanosis of nasolabial ring. Acute pneumonia, stenotic laryngotracheitis. General cyanosis is typical of foreign body, exudative, pleurgy, acute pneumonia, stenotic laryngotracheitis. Acroscyanosis is typical of congestion in the small circle of blood circulation. Chronic hypoxia. Fingers are in the forms of drumsticks and nails in the form of watch glasses is typical of also congestive in the smooth circle of blood circulation, chronic hypoxia. On the slide you can see acrocyanosis and pericyanosis. We will take a 10 minutes break and continue. So continue. Next we will talk about the physical examination of respiratory system. Chest symmetry, supra and subclavian forces. Direction of ribs, usual, vertical, horizontal. Type of respiration. Thoracis, abdominal, mixed. Depth and rhythm of respiration. Superficial, deep, rhythmic, arrhythmic. Respiratory rate. Movements of chest in respiration asymmetry of motion. Scapular postures. Attachment to ribs, wings, shaped scapular symmetry. We'll talk about how to measure and assess the respiratory rate. Change in breathing rate. Tachypnea, increased breathing rate. More than 10% of the age known. In healthy children with excitement, physical exertion, in patients with respiratory and cardiovascular system damage, anemia, fever, pain, and distress syndrome. Bradypnea, shortness of breath. In children, it is rare indication of exhaustion of the respiratory center, coma, poisoning, change in breathing rhythm, the breath of change stalk, bite, co-smell. They are not noted in severe forms of meningitis, encephalitis, positional, intracranial injuries, uremia. Arrhythmic of respiration. Chain stalks, bite, crocus, smells, deep inhalation and exhalations. Dyspnea. Inspiratory with a difficult sonus exhalation, with an abstractal in the VDP, true and false group, foreign body, abscess, with the participation of axillary muscles. Expiratory, with difficult prolonged exhalation, performed with the participation of the abdominal press, with narrowing of the smooth bronchi and bronchialis due to hypersecretion, or bronchial asthma is due to spasm. Mixed. It is difficult to inhale and exhale, with damage to the bronchi, lungs, pleura, heart diseases, and difficulty in blood circulation in the small circle. On this slide you can see the case of dyspnea. The degree of subcostal, intercostal, and sternal precision is a more useful indicator of severity of upper airways obstruction than the respiratory rate. The next topic is palpation. During palpation, we establish tenderness along the ribs and costal nevus points. Resistant of chest, longitudinal and transversal direction, moderate, decreased, increased. Vocal fremitus, anterior, lateral, posterior, identically strengthened, weakened, pleural friction sounds. To assist fremitus vocalis, we place hands on the chest, side and back, and ask the patient to say 33. We determine how clearly the sounds transmit through the body. In children, it is more difficult to perform this examination because of the weakness of their voice and the predominance of high tones. In young children, because they cannot be forced to pronounce words containing r, voice trembling is examined during crying, screaming, and coughing. The weakening or absence of voice tremor on the sick side allows you to distinguish exudative pleurisy from pneumonia. On this slide, you can see the assessment of chest elasticity or resistance. At the same time, both hands compress the chest from the front and back along the middle line and at the sides. Significance of the study of resistance of the chest. Normally, this manipulation gives a feeling of elasticity. In pathological conditions, exudative pleurisy, compaction of the lung, emphysema, pleural tumors, there is a feeling of increased density. In children and young people, the chest is usually resistant, elastic. In the elderly, the chest is difficult to squeeze. We'll continue talking about the physical examination of respiratory system. Percussion. Comparative percussion, character of percussion sound over symmetric parts of the chest, changes, duller, dull, tympanic. Topographic percussion, height of the lung apexes, anterior, posterior, lower bodies along parasternal, medial, clavicular, anterior, medial, and posterior, axillary lines, scapular and perivertebral lines. Mobility of lower bodies of the lungs along medioclavicular, medial axillary, and scapular lines. Below are direct and indirect percussion techniques in children. During percussion, we compare symmetrical lung segment. The spots are to the right. During auscultation, spots are to the left. Healthy lung tissue result in clear sound. Shortness of sound is observed during inflammation of the lung tissue, fluid accumulation. During auscultation, we assess the following: character of respiratory sounds over symmetric parts of the chest, musicular, respiration, bronchial, tips, strange, increasing, decreasing. Invitation sounds, rails, dry sibilant, sonorous, moist fine, bubbling, medium bubbling, and coarse bubbling. Crackling, consonation and non-consonation, crepitation, pleural function sound, slide, and rolls. Bronchophonia on symmetric parts of the chest, identical, increased, weakened. Special rules should be followed during auscultation. The first requirement is silence in the room and the absence of any extermination, sounds that might mask the sounds heard by the physician. The ambient temperature should be provide comfort for the undressed patient. The patient should be in a comfortable posture. the skin to reach to the bill of the phonoendoscope is pressed should be hairless because hair produces additional friction which interferes with differential and interpretation of the sounds. When using a stethoscope, its bell should be pressed firmly and uniformly to the patient's skin, but the pressure should be moderate since excess pressure dampens vibration of the skin to diminishing the intensity of the sounds. Next, we'll talk about tips of breathing. Vestibular breathing mechanism. Vibration of elastic wall of alveoli characteristic, soft, blowing, intensive during inspiration. Diagnostic value at normal state of health. It's auscultation at all the surfaces of lungs, but it is typical for mild axillary and interscapular regions. Bural in children under 3 to 5 years of age. The entire inhalation and exhalation is listed in 2. A thin chest wall, intestinal tissue is developed. Should distance from the voice box slits to the listening area. Pathological bronchial breathing. Laryngotracheal breathing. Hard breathing. Rigid toe breathing. Pathological weakening of breathing. Saccadic breathing. Dry sibilant rails. Basal rails. Small bubble moist rails. Foaming. Middle or large bubbling moist rails. Concernating or non-concernation moist rails. Crepitation, pleural friction. This is the end of our lectures. Thank you for your attention. Goodbye.